The information in this broadcast is for educational purposes only and is not provided as a professional service, medical advice, or is it intended or implied to be a substitute for diagnosis or treatment. You are encouraged to confirm any information obtained from this broadcast with other sources and review all information regarding any medical condition or treatment with your physician and other appropriate healthcare providers.
Hi, I'm Pete Levine. Welcome to Noggins and Neurons, Stroke and TBI Recovery Simplified. I'm a clinical instructor and clinical researcher. I've co-authored dozens of scientific journal articles about brain injury recovery, and I'm also the author of the book, Stronger After Stroke.
I'm Deborah Battistella, occupational therapist, creator of the OT's Guide to Mirror Therapy, and an OT educator. I have a lot of experience working with survivors. Most of my clinical practice has been in a certified stroke center. Pete and I are especially interested in talking about what rehab, neuroscience, and clinical research all have to say about the brain and recovery. But don't worry, our job is to make this stuff simple.
We're here to make it so that everyone, clinicians, clinical students, caregivers, and most importantly, the survivor, understands what it takes to leverage their great neuroplastic brain for recovery.
Hey everybody, this is part 2 of the interview with Doctors Don Neumann and Barbara Zupan. They'll continue to describe alexithymia and what to do about it. Alexithymia is sometimes a sequelae of brain injury that makes it difficult for the survivor to recognize emotions in others as well as in themselves. I'd like to remind you that if you want to donate to our humble podcast, there's 2 ways to do it. First, you can Venmo, and our Venmo address is @Neurons. There's also a PayPal QR code that you can scan on the Noggins and Neurons Podbean site. We have a lot coming up in terms of guests. Upcoming episodes include 2 certified stroke rehabilitation specialists, Jenna Coleman, an occupational therapist and owner of Trio Rehab down in Texas, and Suzanne McCrum, a physical therapist, also of Trio Rehab. Later in October, we have 2 physical therapists, Meredith Drake and Jennifer Miller. Later in October, we have 2 physical therapists, Meredith Drake and Jennifer Miller from the Ataxia Center at Johns Hopkins, to talk to us about how to treat cerebellar ataxia. We'll also have a cerebellar stroke survivor who has ataxia, Stephen Heim, who is also an acute care nurse, and so he knows about his own pathology sort of from the inside out. We're going to get a great perspective from him. He taught the Miami Emergency Neurological Deficit, the MEND exam, which is one of the tests used in intensive care and the emergency department by nurses to help diagnose stroke. So that's going to be a great episode. And then there's a bunch of other cool stuff that we have scheduled, but let's get on with this episode with Doctors Don Neumann and Barbara Zupan.
I think as therapists, if you're really looking for something tangible to use, just grab a movie or a TV show and, stop and pause at various scenes. Like, I think that would be a really useful task that you could get that more, I always say ecologically valid, but that more everyday way. I mean, it's still acting, but it's a better example of how we use and express emotion and the way we need to use all of the cues around us to interpret not just one thing. So I think that that's a really good thing that therapists could look to do.
All right, what did you guys do? Did you check on the dog?
Checked on the dog, yelled at the fiance.
When are you getting married? So my daughter is going into speech therapy. She's going into her senior year.
Oh, that's exciting.
Where?
Well, that's a good question. She did well on her. What is that test that you take that I always forget? It's not the MCAT. It's the...
The GREs?
GRE. Yeah, she did well. And she did well in math, which shocked all of us, her more than anybody, I think. What? Math? No. So now she's trying to figure out where she can go to maybe help mom and dad pay for the darn thing. And she got some help with the director of her of her program. You guys have any good suggestions for schools for my daughter?
But where are you located? I'm sorry. I should probably know that.
Cincinnati. She goes to University of Cincinnati. Somebody said Toledo was real good.
She should go to Fredonia.
What? What is that? Is that a place in Italy?
It's a SUNY school.
Oh, it is?
Yeah, it's actually, Fredonia's not far from where Dawn and I did our degrees at Buffalo.
Yeah.
I'm like, it sounds vaguely familiar, but I don't know anything about it.
It's a good speech school.
Is it?
It is actually. They've got a good program.
Mm-hmm.
Okay, I'll suggest it.
I think IU Bloomington is supposed to have. I know a couple, like the speech therapist that I know there that trains clinically, Rebecca Eberly, who wrote the social cognition chapter with us, Barb. She they're awesome. Her and Laura Kirchner, I think it is. They're great.
Peter, why don't you send her to Rockhampton, Central Queensland?
Yeah.
My program.
She'd love that.
Yeah.
Hey,
Pete?
Barbara,
She's not allowed to listen to this podcast?
No, absolutely. My wife is Finnish. She's from Finland. And we often try to get our kids to go to Finland because it's free. And we have family there. But I bet Australia would be a better choice because in Finland, half of the year, you're freezing your off. And that's no fun. And it's dark. But Australia just sounds like the best place in the world.
Even winter here is, I've got to do the math now, it's about 70 to 80 degrees in the daytime during winter here.
And no masks. No COVID.
But they can't leave.
What? Oh, well, they can't leave.
They have to stay home.
That country's ginormous. They can go anywhere they want.
It's kind of true.
Well, good. Did anybody come up with any good discussion points? Because I have a question, but Deb, did you come up with anything or?
No, I've just been thinking about everything we talked about.
How might you tell? Like, is there a big difference between cognition and alexithymia? Can they obviously affect each other? Are they that separate? Are they processed differently? Might the problem that we were talking about before, where clinicians go in and there's the hubbub of rehab and everybody's working on everything and you're trying to get them walking and doing everything else, is some of the emotional inappropriateness or inability to interpret emotions, is part of that just a belief that it's a cognitive problem? And so they just go, yeah, it's cognitive. He has brain injury. That's not even a question, is it?
No, I think it's a great question. And it's an interesting one because I used to look at alexithymia as it's an emotional issue, but the more I've gotten into this, the more I think about it, the more I realize it. So it is an aspect of emotion regulation, but and emotional processing, but I very much believe it is a cognitive act. It's cognizance, it's awareness of your emotions and the cognitive ability to label and describe. When you're labeling and describing your emotions, you're pulling in prefrontal cortex. So it's very much of a cognitive act of evaluation and understanding of those emotions that helps you then to regulate and control those emotions. Does that make sense?
Yeah, it's almost like a cognitive appraisal.
It to some degree, yeah.
Yeah.
Mm-hmm. But in the cognizant awareness too. And then I've had people ask about, well, you have the general self-awareness, right? In brain injury, right? A lot of people with brain injury just lack complete self-awareness of their skills and their abilities. And I feel like alexithymia is very a specific lack of awareness. That just because you have alexithymia doesn't mean you have a more global self-awareness deficit necessarily. But there's that kind of that metacognition, that self-monitoring, evaluation. That's all involved, and it's very cognitively oriented, I believe. And then you get into the empathy, and then you have empathy where I feel like then you're breaking it down. It's like you have cognitive empathy, you have emotional empathy.
I think something else that was really interesting and something that we found, and I think it's important to mention, is also recognizing that sometimes people actually aren't expressing an emotion. So there's times where we say something and our emotion is neutral and it's meant to be neutral, and trying not to read into that. So one of our studies that we did found that both people with and without traumatic brain injury didn't do very well at neutral. partially because the study was based on emotion, right? So there's that bias. So in general, people were looking for emotion. But where the real interesting difference was, people with traumatic brain injury, if they didn't recognize the neutral, they tended to lean towards identifying it as a negative emotion. Whereas people without brain injury lean towards a positive one. So it was almost like that difference in, they're expressing nothing, but they must be feeling something. They must be mad at me, or they must be feeling something negative. And so you can imagine how that plays out in an communication as well. And so I think, some of those kinds of things are important for people to recognize, that if they're responding negatively and you did nothing, you need to be very explicit and say, no, I wasn't feeling angry with you. I wasn't feeling annoyed with you, because I think they might be reading something that's not there.
Whether it's projection of them having these negative emotions themselves and it's kind of getting projected on somebody else when there's a neutral response. But some of the other research that I've done on something called negative attribution bias, and how people with brain injury, when they are interpreting other people's intentions, there are a subset of people who are more inclined to just assign more negative interpretations of people's feelings and people's behaviors. So that's going to play out whether you're, interpreting the emotion or interpreting why somebody's doing something. There's just this, inclination to kind of see it in a more negative light.
Yeah. If in eye tracking software, when they track the eyes and they try to pick up different parts of the face, I saw some research into autism, and autistic people tend to focus on the mouth more than others do. Is there any insight into visual tracking and where people who have brain injury make a mistake in what they're looking at?
No. Do you know of any research on that, Dawn? I haven't. I know that when we did our treatment, we were really cognizant of, we'd focus in on what are the eyebrows doing and what is the mouth doing and all of those things. But then we would also focus them back in. Now let's look at the whole face. So we made a big effort to ensure they weren't just looking at, one cue, that they might use different cues for different emotions, that, sometimes the eyebrows are more a better cue than the mouth, for instance, depending on the emotion. But then we made them look at the whole face and talked about the face as a whole. But Dawn, do you know of eye tracking that mapped that?
Yeah, I did it.
Oh,
what?
but honestly, no, that's okay, because it's only an abstract that's published, and we're actually working on a couple papers right now that are under review. But so you wouldn't know. But going back, but this is relevant, so I gotta pull it in. So what Barbara's saying is, so when we recognize other people's facial expressions, right? They're constantly changing and they're dynamic, and so it's happening really quickly. And so there's a lot of research to show that when we're visually processing the face, we do this in two ways. One of the ways is we process the face holistically, meaning we're looking at it all together as a whole, and we're seeing it as kind of a one thing, right? And so doing that allows us to very quickly look at somebody and say, this person's sad, this person's angry. You could do it in less than 1 or 2 seconds to be able to know that. We also look at the features individually, separate, feature by feature. We do that, but we would never be able to recognize emotions quickly if we didn't look at that face as a whole. And we did some research. So the neuroimaging research that we did, we wound up finding we took people with traumatic brain injury who had impaired facial affect recognition, and we compared them to people with traumatic brain injury who had normal facial affect recognition, and people healthy controls who had normal facial affect recognition. And the part of the brain, what we saw is that people with traumatic brain injury who had impaired facial affect recognition had reduced activity in the part of the brain that's responsible for holistic facial processing. So we're seeing that's part of the issue, that they're not pulling it together. So I think that was a huge strength of the intervention that we did, is that we always brought it back into, let's pull all these pieces together. What does the face look like as a whole? You're never going to get the answer from just one feature. You need to kind of look at the whole picture and what you're seeing.
one of the things that we know about people with brain injury is that they often have visual perceptual problems or just vision deficits that go undetected. So I'm just wondering, do you test for that before you do the research? Or that, I guess it's like a two-part question. So part of it related to the research, and then just in general, maybe a wondering if part of the difficulty that people with TBI have in recognizing the cues is their visual perceptual problem.
Yeah, it's a good question. I think it's a little bit of a limitation. So we did not formally evaluate their vision. I know for our affect recognition, the intervention study, we looked at, what did we do? We did look at their ability just to process, so face recognition in general, so face perception, we looked at that. But I think
we also did the visual scanning. So you know how people who have right hemisphere damage can ignore one side. So we did do some visual scanning tests as well as part of our battery before doing the treatment. But we didn't, that's about the level of what we did from visual perception. We didn't test it as fully as we could have.
Right. We looked at visual neglect and broader face perception, but we did not look at kind of more nuanced, like visual perception problems. I think we were kind of asking, we're like, do you have any visual impairments, that uncorrected visual impairments that are going to impede? As far as our eye tracking data, so they had, and the machine that we used, they had to get calibrated to track, so they would have to follow a ball across the screen, and they would have to get calibrated. And if they didn't, they had to achieve a certain level of calibration to be included in that. But that still doesn't, there still could be problems, right? And so we actually had to throw out data because sometimes the data was off. You could see that, it was problematic. So I think that there's more to be done with that. And I think what really needs to be done, where we want to go with this, is so where is the breakdown occurring? Is it a lower level visual perceptual problem? Is it a saliency issue? And what I mean by saliency is, do they know what to pay attention to? What are the cues that are important that they should be looking at? Or are they looking at those important cues and not making a connection and being able to interpret those important cues? So there could be all kinds of issues. And depending on the person, like we were talking about before, everybody with a brain injury is different, and there's a diffuse injury. So some people, everybody, the issue behind everybody's problem may vary depending on where the injury is.
Yeah.
But important to know if you're going to do treatment, right? So it would be, to be able to personalize and focus what you're going to do.
Yeah. Can I go back to that other intervention when we were talking about the movies? Well, it seems to me that could be an intervention that would be helpful to do in a group where you specifically select people with TBI at different ability levels. So some people who have lower abilities to recognize and interpret, and some people who have improved in that area, or who just never had really a deficit in that area, and do the intervention with conversation among all of them. So that I think there's a value in peer learning, because, when you've got the expert coming at you all the time, I cannot imagine that would feel very good.
I love that idea, Deb. And I do think there has been some of that communication groups training stuff talks a lot about that peer learning being a big component of why it works, or why it's important in terms of doing that group scenario. So I agree. I think doing the movies, and even just, it gives people opportunity even to share similar, I had a similar experience, but I didn't feel that emotion. I felt this emotion, and talking about why is it different for different people? Because that's also a really typical thing to occur, that sometimes you might feel angry in a situation, but it would actually make me feel sad. And being able to talk about that and the whys, and what kind of pieces of that scenario would lead us to each respond differently. So that group scenario would really support that well.
Mm-hmm.
Yeah, it's a great point. I know a lot of people, they're huge believers in the group therapy. I mean, and I've done a couple things with group therapy. We didn't in this emotion recognition stuff, but I could absolutely see the value. And I know the patients love it. They think it's such a huge component to it, to see other people who are struggling with similar issues, but to have that feedback. You're right. I think they're so much more receptive to get the feedback from a peer, than therapist.
Mm-hmm.
And peers, frankly, will give feedback in a way they would receive it in everyday life. So if they say something inappropriate or even something really well, the feedback is going to be more authentic than as a therapist. We're very conscious of saying it in just the right way. We'll call things out, but we do it with our professional hat on. So I also think there's a lot of value in that, in responding to feedback that maybe you don't want to hear, or even how to respond to positive feedback. I think even that piece is what makes that group dynamic so important.
How much does the autism research cross over into the field that you guys are working with? Is it useful at all, or is it just completely disparate pathologies?
We've actually used the autism research. We used that a lot when we developed our treatment program. So we essentially took the concepts and ideas from that research, but then layered over top the strategies and approaches and things that we know work for people with brain injury. And also, much of that literature in autism is on kids, and we were focused on adults. So making sure it was, age appropriate. But yeah, I think there is a lot of overlap between the two. And I think that you can certainly learn a lot from both sets of literature. It's just, like I said, the stuff with autism tends to be on kids. So some of the consequences of the problem can be described quite differently, because they're talking about the way emotion regulation and social emotion impacts children through development, versus now we're talking about people where it should already be developed and they're using emotion in a much more advanced way. So I think that piece is quite different, but the general underlying concepts are similar.
We look to it a lot, for sure.
You guys have you looked at peds at all?
No, there are people doing some work in peds in this area, and I've read a little bit of that literature over the years, simply because when I was a speech pathologist, I was a pediatric clinician. So
I forgot that.
So I did, years and years of work with pediatrics. So I'm definitely interested, and I've read it and I've referred to it. But we ourselves have never looked at pediatrics.
I'll just leave it at that. I deal with the adult population.
Okay, yeah, let's get that one done, and then maybe we can superimpose it on kids. I wonder if it's harder with children for a variety of reasons.
I mean, they haven't necessarily developed those skills, so you're teaching. It's brand new. It's not like reteaching something that already existed. It's a brand new. So,
and you can't rely. There's also language issues with language development with kids, and so the way you talk about emotion and the way you make them think about it in terms of training the skill, if you want to think of it in that way, is also very different, right? So you're relying more on pictures and toys and examples and things like that. So the way you approach it is an entirely different place.
We'll leave that to some other researcher.
You got your own problems. I understand.
I want to go back to when we were talking about training, like identifying emotions and then helping people to, recognize what they're feeling and then be able to interpret another person's. But do the people who go through the training, do they report being able to feel more? Because I think life is more rich when you actually feel something.
We had one person, and Don probably knows exactly whose story I'm going to tell, but when we first started the training, he was someone who was that very flat affect, and there was lots of issues with his wife because of his inappropriate responses to things or lack of response to things. And we did the training. And after the first week, because we were having him make the emotions in the mirror and things, he came back after the weekend and said, my face actually hurt on the weekend. And he realized, and was he about 15 years post, Dawn? He was quite.
I don't think it was that long. I want to say maybe 5 or so, but.
Oh, I was thinking he was longer. But he was quite a ways out from his brain injury. And he said he recognized he hadn't, must not have ever used those muscles in all that time. So that increased his awareness. And he was commenting that things like going golfing with his friends were becoming a better experience because he was recognizing how they were feeling and asking them more questions. So whether or not he was physically associating those emotions and feelings more, I don't know, but he certainly reported huge impacts in his personal life. And his wife also reported some pretty significant changes. Don probably has better examples, but that's the one I always remember because it was so poignant that, the whole my face hurts.
Yeah, because he went home and he practiced in the mirror and he thought it was like fascinating. And the fascinating thing about him is going back to that whole self-awareness thing. He came into this program. He had no self-awareness. He had a problem. The only reason he came into the study is because his wife literally forced him. And he was like, okay. And I'll never forget the comment he made. He said, I'm earning my angel wings by being here because I don't need this. Like that he was doing us a favor, and he was. I mean, obviously, every research participant is helping us out and doing us a favor, not just us a favor, doing the brain injury community a favor, right? But he didn't think he needed it for sure. And I watched self-awareness develop in front of my face, which was fascinating, I think. And he like within a week, he had total buy-in to this. Wow. It was amazing. And he made that comment about the interaction with his friends golfing, that it was just so much more of a rewarding experience for him, that it was, it was really interesting, like to say like, oh, these are the things you need to have that connectedness with other people. And that makes it important and meaningful. So that was really cool. Another example, and I've had this happen now a couple times, and we wound up doing a poster at ACRM of this more recently. But way back when we were doing the dissertation, I remember one of the our subjects, our research participant, her mom said she cried for the first time ever since her brain injury. Now, I don't know if you guys have heard this, but I feel like I heard it. I used to work clinically a long, long, long time ago, and I felt like I heard it fairly regularly, that some participants, in contrast to being this kind of labile and overly emotional, kind of you couldn't cry. It was like almost like this emotional constipation of not being able to express this. And if you think about like what a release it is to be able to cry when you're sad. So this person felt sad, but didn't have the release of it. I've heard this numerous times. And so going through our program, it was the first time somebody was able to cry. And then more recently with one of the, so at the Rehabilitation Hospital of Indiana, one of our speech pathologists, she went through the training, learned how to do this. So she does this clinically at our hospital. So they do assess for it, they do it clinically. And she had a patient. Oh, one of our physiatrists, our medical doctors in our physical medicine rehab department, she had a stroke patient, and the patient's biggest complaint was she could not cry since her stroke. And so the doctor knew about our study and knew about this type of things that can happen and referred this patient to the speech pathologist to get this intervention training. Yeah, which was really cool. Now, it's not like by the end of the training, the patient didn't full on cry, but she did shed some tears and definitely had some insights into her emotions and had more connections with her feelings and had a little bit more kind of release of those feelings. And yeah, so it was really neat. We did a poster on that at ACRM.
That's incredible. I'm starting to hear commonalities with people who have psychiatric problems, and some of the medications make them lose their feeling. They become more flat affect.
There's actually a lot of literature. So when Peter was asking about the crossover with autism, there's actually a lot of literature that shows significant crossover with schizophrenia as well. So it is fascinating that you do start to see these overlaps with the same sorts of issues and problems and concerns. The way you treat them might look slightly different depending on that underlying cause, but this is a more common problem for many people than I think people recognize.
Yeah, absolutely. Yeah, and then it gets to be really complicated too, because then after a brain injury, I feel like a lot of people with brain injury get misdiagnosed with issues because most physicians aren't really necessarily familiar with the consequences of a brain injury. Mm-hmm. And so you're going to see people, misdiagnosed with bipolar disorder or borderline personality disorder or all kinds of stuff that's not necessarily really what the issue is. But you do see it outside of brain injury. You see a lot of these problems in other, affective disorders. Mm-hmm. So it's not uncommon.
Yeah. I think it goes back to what we were talking about earlier with people not having a full understanding. And I think another piece of that puzzle is people not knowing who can help with certain problems. And I'm in a couple of brain injury Facebook groups, and it seems like survivors feel like their doctor doesn't get them or their doctor doesn't care. They're falling through the cracks. They don't know what's wrong with them. And these people want help. And I don't know how much of it is lack of insight, lack of them thinking that they're not a part of the problem, but to understand that you're not getting the help that you need leads me to believe that there's some insight there.
Oh yeah, there totally is. And they're not getting the help that they need to. I mean, there's a huge gap. I feel so fortunate, I think, to be where I'm at, but like, I'd be curious of your listeners here, how many people have heard the term physiatrist or physiatrist, depending on how you want to pronounce it. I know it could go both ways, but I believe that everybody who has a brain injury should have a physiatrist. But 90% of the people I talk to who've had a brain injury, and I make that comment, they're like, I have no idea what you're talking about. They think I say podiatrist. I'm like, it's not a foot doctor. It's the other end of the body. It's the complete opposite side. And there's just not enough, and then there's not enough physiatrists in the world. I do know through ACRM, the American Congress of Rehabilitation Medicine, they have one of their, the brain injury special interest group has a task force within it on chronic brain injury. And they recently developed a tip card for primary care physicians. And this tip card is like, hey, here's stuff, here's information about a brain injury, and here's what you need to know, and it's like a two-sided tip card, I think, which is just, it's awesome, right? So whether the person with the brain injury brings it in or the physician, they're trying to distribute it, disseminate it all, throughout. So all over the place. So getting that word out there, because these primary care physicians, need to have more awareness and acknowledgement of these types of problems and what they should be doing and who they should be referring to.
Mm-hmm. I think about the validation of that. So for people with brain injury who are everyone's saying, no, we've treated what we can do. And they're like, no, but there's something else. And I know, I want more help, or I need more help. And their family members, to have someone say, well, let's look at the social communication or the emotional responses to things, and let's sort of see if that's what's underlying all of these other issues, to sort of feel validated, like, oh, yes, that is me. Yes, I do have trouble with that. Or the partner recognizing, yes, they don't respond the way I would expect. We saw so much of that when we worked through our study and meeting families, because part of our study was we actually had family members or carers complete information as well, so we could see if they saw differences. But so often we heard finally somebody is recognizing that this is a problem, or somebody is raising this as an issue, because they didn't have the words or the information to even describe why it was a problem or what the problem was. So when we attached words to it, the family's like, yes, that's what's going on. That's where we're struggling. And it was, I think that alone often went so far for people, even without the treatment, just the fact that we acknowledge what was wrong.
Having kind of a diagnosis. Somebody has
in an unofficial way, but just exactly sort of identifying, what was causing all these different breakdowns that they couldn't figure out.
Well, and on both sides, they think they're crazy,
Mm-hmm.
It's hard. It is hard because it's coming out in a behavioral way, but you don't necessarily know where the breakdown is, but you're just like, something is totally off and I don't know what that is. And then you learn like, oh, they might not be able to recognize what you're feeling, or they have, it's like, oh, wait a second, this could be a huge piece to the problem.
Mm-hmm.
It's validating.
In your work, your efforts, your studies, have you come across people who use drugs and alcohol as a coping mechanism, who learn from you and realize that they don't need that type of a coping mechanism anymore?
In our original treatment study, we actually excluded people who would be considered alcoholics or have significant drug or alcohol use. If they were just doing this sort of normal use, we that was okay. So we actually don't know that. Donna, I don't know if you've looked at that
I can't believe you remember that detail. I completely forgot that. Wow. No, not with that study. No, I don't know. So the other study that I'm doing with the alexithymia intervention, teaching people to have insight into their own emotions, that's a whole separate intervention that we're doing now that we're evaluating with a randomized controlled trial. We had a pilot study that we did that. This alexithymia is actually highly correlated with poor coping skills and substance use. I mean, if you think there's different etiologies or reasons behind why somebody has an alexithymia. Like, so it could be neurological damage that disrupts a person's ability to access their emotions and be able to define and describe it. But our patients could also have alexithymia from before their brain injury as well. So, because it could also come from just kind of how they were raised, and kind of, if you think about, were you the child that was raised to get in touch with your emotions and talk about your emotions and this is okay? Or were you that child that was raised to believe like, oh, emotions are taboo or whatever? Or, it could also develop from being exposed to psychological trauma, and it's almost kind of a negative kind of coping skill, right? So if it is in that vein, you're coping or dealing those emotions. The life stressors are still coming, right? So you got to deal with it in one way or another, and a lot of times they're choosing these not great coping mechanisms, and substance use can be one of those. That's research that's outside of traumatic brain injury that's connected to alexithymia and substance use. So we're also looking at this relationship now in a current study with the relationship of alexithymia and substance abuse in people with traumatic brain injury. We have added an outcome measure to our current study to see if it does change anything with substance use.
Hey everybody, I wanted to talk to you about something that's really important. Recovery from brain injury. Since 2016, I've been doing consultations with stroke survivors and survivors of other forms of acquired brain injury. I get together with them on Zoom for about 45 minutes to an hour, and we have a good long chat about how their recovery is going, where they are in the process, what their ambitions are for their recovery, and what's holding them back. Often a caregiver is also in the meeting, and sometimes clinicians show up. Anyway, we end up talking about anything under the sun that's involved with their recovery. And then I take a few days, do the pertinent research, and email them back a sort of recovery manual dedicated to their specific recovery. Often it's stuff that comes straight out of neuroscience and neuropsychology and emerging technologies. I email that manual back to their survivor, and every one of the suggestions in the email has clickable links to more information. I'm going to be putting a link on the show notes, but probably the best way to find out how to set it up is to email me at my personal email. And that's strongerafterstroke, 3 words, all stuck together, no spaces, strongerafterstroke@yahoo.com. You don't have to email me anything. In fact, all you have to do is write consultation in the subject line, and I'll email you back with how to set it up. It's that simple. strongerafterstroke@yahoo.com. So let's get together and jack your recovery up. That's right.
Outside of the brain injury world, there's a researcher at Wayne State University who looks at chronic pain and has developed an intervention called the emotional awareness and expression therapy. And he does this with people with all different types of chronic pain, not people with traumatic brain injury. And essentially, it is addressing alexithymia. If you think about it, it's emotional awareness and being able to express those emotions. That he has had tremendous success with that intervention for people with chronic pain, which is one of the reasons why we are looking at that relationship now in TBI, because if we can take our alexithymia intervention in our patients with traumatic brain injury who have chronic pain, wouldn't that be cool if we can reduce their chronic pain?
Mm-hmm. Yeah, sure would.
Yeah. I mean, the idea there is that if you're not processing and dealing and confronting those emotions, that psychological distress is manifesting through other mechanisms, somatization, it's coming about, whether it's going to come out in headaches or stomach aches or what have you, because they're there. It's not to say that emotion is not there, that it's just not being properly processed and worked through, and it's going to come out one way or another. So let's kind of identify it and deal with it.
I have an infographic, and you know how they're never wrong. I've been staring at it since we first started thinking about talking together. And I just want to go through some of the things that they say are signs of alexithymia. Obviously,
you found an infographic?
Well, yeah. Oh, yeah. I got an infographic.
Wow.
People send me infographics for stroke for my blog, and they're always almost right, but they're kind of not right. Yeah, they're missing something. So obviously, confusion about others' emotions, obviously. Difficulty with introspection. Is that one? Do you agree with that?
And I think that goes back to what Deb was saying before, a little like you have that interoceptive awareness, but also, introspection is a part of that, and being able to kind of that self-reflection and internal being able to, I would say that would be.
Yeah, because you're trying to figure out your emotions. And if you can't do that, then.
Yeah. I can almost guarantee you where that comment is coming from. So the big famous test of alexithymia is the Toronto Alexithymia scale, which there's some controversy about, but that's neither here nor there. We don't need to go down that rabbit hole. But there's several subtests to that. And one of the subtests is something called externally oriented thinking. And that just means that you instead of internally reflecting on your emotions, you are more interested and more likely to focus on the external world and external cues, but not anything internally. So my guess is that's where that piece is coming from.
Yeah, I would have said the same thing. I was thinking externally oriented thinking as well, Dawn.
How about this one? Limited creativity.
See that a lot. That's has to do like that, and it also overlaps with the perspective empathy piece, Barb, kind of that fantasy scale thing.
Oh, yes.
Yeah. I don't understand. I'm going to be totally transparent. I don't understand the connection there. I don't see how, if you have alexithymia, how you lack creativity. I'm not sure I get that one.
Infrequent dreaming.
Frequent dreaming. I've never heard that before.
You haven't heard that one? Okay.
No.
So it's an infographic. It can't be wrong.
Starting to wonder if I have this problem.
That's the problem. Yeah, every time people come on and talk to us about problems, we think we have it. It's like taking abnormal psych in college. You're like, I am schizophrenic, I'm sure. What about logical thinking? Obviously, that would, because it's so cognitive and it's emotional, part of being understanding your emotions is being logical. So that would be affected, right? Logical thinking.
I love how you just said that. Sorry, go ahead, Barb.
I was going to say, absolutely, I see that connection because there's also a lot of information, not specific to alexithymia per se, but to emotion difficulties and decision making for probably exactly that same reason. Because when we make decisions or you think through or reason a problem, generally part of that logical thinking or critical thinking comes from emotionally what's going to happen. So how will that person respond and what will be the impact on you? And usually the impact is an emotional one. Will you feel good at the end or feel bad at the end, right? So if you can't recognize all those emotions involved, it will impact that for sure.
I love this question. And so, the reason why I'm actually loving it and a little bit surprised is because a lot of people think that emotions have no place in a logical world. And you get people that think that all the time, and that's really not true. And I don't know if you guys have ever heard this, but I learned this term from one of my neuropsychologist friends at RHI, Dr. Sam Backhouse, and she taught me about something called wise mind. I don't know if you guys have ever heard of it, but it is literally the combination of logic and reason and emotion. When it comes to making decisions, you can't have just one or the other. These two things need to come together. And it's through the coming together of logic and reason and emotion that helps you to make the best decision for the reasons that Barb just said, right? If you're making a decision, you need to think through, well, what are the consequences of this decision and how am I going to feel if any one of these consequences happened or based on that, this is likely to happen if I choose this path. This is likely to happen if I choose this path. What and how am I going to feel in response to any one of those things? And I'll quote my other friend, Dr. Alan Weintraub, who gave me this terminology. He used this term that I've stolen from him now called emotional foresight. You really need to be able to think through. It's not just necessarily in the moment. Am I going to go to the casino because I like gambling? But I need to think through, if I go to to the casino and I lose all my money and I can't pay my rent, how is that going to make me feel when I get thrown out of my apartment? So yeah, those two things have to definitely come together. So logic's definitely involved.
All right, I got another one for you. You ready?
Bring it on.
Probably pretty obvious. And you start to see how emotional context and understanding your emotions and others just is all throughout the brain and all throughout cognition. So of course they're going to impact on each other. This is probably going to be an easy one for you to just hit it right out of the park. Difficulty coping with stress.
Absolutely.
Yeah, absolutely. And some of that is that emotional regulation piece and recognizing. But then, earlier when Deb was talking about the connection basically with mood and depression and all of those things, all of that gets tied together too. And it's, if you can't, Don was saying, if you have those emotions blocked in and you can't express them and you don't get that release and you don't get the response which is what contributes to the coping, then it can lead to stress and anxiety and depression and all of those things. Don, I don't know if you have more to add to that.
I would just say that that's exactly right. And then Dr. Roger Wood and colleagues out of the UK did a study that examined alexithymia and in relation to different coping styles, and found that people who were alexithymic, who lacked that emotional insight, were more likely to have avoidant coping mechanisms. Hence, going back to that substance use. Substance use is an avoidant coping mechanism. So yeah, so less likely to be able to kind of deal with stress. And then that stress is going to eventually turn into these more chronic emotion affective disorders.
Man, it impacts on everything. How can we get people to pay more attention to this as a holistic part of treating people with brain injury? What do we got to do? Is there something we can do?
I don't know, your show?
Things like this definitely contribute.
Yeah, you guys.
Infographics, Pete.
Infographics. You guys should do a YouTube video about it. I bet.
Well, I do have. I mean, I sent you the Brainline video. Well, they're not. It's not. I mean, it is a YouTube and it's out there, but only a certain amount of traffic is going to be driven there. Although a good amount of traffic has been driven there. I've gotten tons of calls about alexithymia.
And I think the more we can just get the word out. I know when I first came to Australia, there are people. Actually, Australia does a lot. There are a lot of researchers here in Australia who do emotion-based work. But just getting the word out more and getting people talking about it and making it, when Don and I were first starting this and I was applying at conferences like the large American speech pathology, the ASHA conference, anytime I submitted something based on emotion, I got a poster. So I would submit to do an oral presentation and they would always put it as a poster because I think, that's going back some time, but from their perspective, that wasn't a speech pathology target area. It was just this little like, oh, well, that's kind of nice. So we'll just, stick it over here. And they weren't giving it kind of the full stage. So I think just the more we keep putting it out there and keep trying and keep talking about it. And anytime you talk to clinicians and families asking about emotion, it just gets people thinking about it and recognizing that, like you said, Peter, it touches on every aspect of how they're doing. But beyond that, like videos, getting on the news, podcasts, any way you can talk about, I make sure that I put it into my speech pathology course at the university, that we talk about it there. So even in those training programs of clinicians coming up through, I think that it needs to be a component there as well. So it's just advocating, I think.
We had a vision expert on a couple of episodes ago, and it was the same kind of problem. It wasn't addressed because nobody thought to ask people if they could see well or if there was a field cut. And so, yeah, and that would, as you say, Barbara, would come down to a caregiver maybe taking an interest, but also the clinician educating the caregiver to take an interest that this could be a problem, and nobody's testing it probably, but it may very well be testable and it may be treatable.
Yeah, absolutely.
Mm-hmm. Maybe here in the United States, it should be with the discharge planners for those units where people with brain injuries are treated, because people are being discharged often sooner rather than later, or people, they don't want to stay in the hospital. So maybe just some sort of, I'm being serious now, an infographic or some information. If you notice these symptoms, if this is how your life is going, please contact your neurologist, your physiatrist, some health professional who will listen to you.
Yeah, that's an interesting point. Yeah, if we can only get that implemented, right?
Right.
Are there any video applications? I found a couple online of very, very subtle facial expression changes. Wouldn't it be great if you had hours of this? This is kind of what you did in your study, where you were showing people film of different facial expressions.
He just freeze.
I'm freezing, right?
Yeah.
Oh, he's really, really frozen.
He really is frozen.
Yeah.
He
Like
won't
on the
forget.
edge of my seat.
I know.
Okay. Yeah, good. Did I scare you?
Yeah.
I saw the expressions on your face. So what I was talking about was, I'll start where I ended. These videos where there's very subtle changes in facial expressions. Is there a series of videos, kind of like you guys did in your studies, where you show them film of subtle changes in facial expressions, maybe sometimes not so subtle? And maybe that was the gradation, that it started out not subtle at all, and then it moved to very subtle. Is there any kind of video thing that we could do, a repetitive practice thing where the caregiver doesn't, because people have to interact with people other than their caregiver, maybe a whole bunch of repetitions of interpreting emotions through facial expressions might be useful? And is there anything like that that's available?
I don't think there's very much available with those more subtle emotions that are
And dynamic.
Sorry?
And dynamic.
And dynamic. So when it's moving, there's the odd one that's got some pictures that are considered, low intensity examples of emotion. But from a dynamic perspective, there's one or two tests out of Europe somewhere, I think, that do a couple, but they're meant to be assessment tools. So I don't know how useful they would transfer. But this is something I've been working on outside of brain injury, is trying to develop examples of emotion that aren't as obvious, and also moving towards the way in which we label them. Because most of these programs talk about happy, sad, angry, fearful, disgust, and surprise. We don't use those words generally in everyday life. We talk about someone seeming anxious or irritated or annoyed or those kinds of things. So the words we use to describe tend to reflect, probably, like you were saying, Peter, those lower intensities or less obvious examples of emotion. And that's what we see in everyday life. So I do think it's important. And I think exposing people to those kinds of examples would be useful. I'm not aware that there's any around that we could be using for treatment, other than to try to pull, like we've used movie clips in our research, but you could just use a movie and watch a scene and pause it and talk about, well, what were they feeling? And why do you think they were feeling that? What was going on with their face? What was going on with their body language? Because it's all together. What did their voice sound like? What was happening in that situation or scenario that maybe let you make an inference or let you sort of predict that person would respond in that way? Because that's the everyday stuff that we do, right? So I think as therapists, if you're really looking for something tangible to use, just grab a movie or a TV show and, stop and pause at various scenes. Like, I think that would be a really useful task that you could get that more, I always say ecologically valid, but that more everyday way. I mean, it's still acting, but it's a better example of how we use and express emotion and the way we need to use all of the cues around us to interpret not just one thing. So I think that that's a really good thing that therapists could look to do.
That's a good idea. Useful. Thank you.
It's interesting because a group of researchers here in Bloomington, Indiana, in the psychology department that are doing research in autism in this area have been using clips from The Office to evaluate social inferencing skills and doing some eye tracking data with them and evaluating social inferencing with them. So kind of that everyday, kind of more complex, more subtle cues, I guess. It's kind of interesting.
Yeah, that's a weird show to pick on, but
I think so too.
Lots of sarcasm, right? So there's the dry, what's that word? I can't think of the right word, not the dry, but that sarcasm that's sort of subtle. Actually, so you reminded me of one of the other things. So obviously we were talking about how like lack of time and inability to kind of test these things, and it's not included in the traditional battery and stuff. One of the other studies that Barb and I were involved in that we did is a quick indicator of emotion, perception, and empathy deficits, lack of smell.
What? Really? That's COVID.
I know, actually. So I've actually been told that I've been told that we should be looking at empathy in COVID patients who've lost their smell. Barb, let's do that. On that next week. But prior to that, so people with traumatic brain injury, actually, over 50% of people with traumatic brain injury lose their ability to smell. And that has to do with largely the fact that the olfactory bulb and nerves are located just kind of right around the prefrontal cortex. And a lot of these injuries are that prefrontal, that right in front of your head. And so it's causing damage to that area of the brain. So your olfactory senses, your ability to smell and taste often get affected. But it's also the prefrontal cortex is kind of where all of this empathy is, and social monitoring and all of this other stuff is, because of the proximity of those olfactory nerves. I feel like that prefrontal cortex, where everything is kind of coming together, when that's damaged, you're gonna see these deficits in smell. And so it's just so the one study that we did, the sensitivity of dysosmia, or that loss of smell, I think it was 70 or 80% of predicting an emotion perception deficit. And then we found out that people who had impaired smell had significantly lower empathy.
Wow.
Not everybody's aware of a lack of smell or taste. Many people, probably 50% of people are aware. And it often is if they lose their sense of taste and they're like, oh, I can't taste anything anymore. Oh, I can't smell anything either. So if a clinician hears their patient saying that, that should be a red flag. Oh, I bet you're going to have, emotion perception problems and empathy problems.
It reminds me that the test for Alzheimer's, the one where they have them see if they can smell peanut butter, and if they can't, it's it's a precursor to development of Alzheimer's or dementia. Yep.
Because of the parts of the brain that are being affected or surrounding that area.
Okay, I got one more in the infographic. You ready?
Yeah.
All right. And Dawn, you definitely mentioned it. Barbara, I think you mentioned it as well. What? Aches and pains from stress. It says from stress, but what's the pain connection between emotion and pain, like physical pain?
I think it's that idea that if you are not dealing and processing those emotions, that those stressors, right? So you're confronted with stressors, and if you're not processing through that and dealing with it, it doesn't go away. You can't just ignore it and kind of tamp it down and it's gone. It doesn't work that way. You may not be cognizant of it, but it is manifesting in all different kinds of ways. So I think that it is kind of kind of eking out in other areas. The other thing I do want to say with alexithymia, its relationship, I think I had mentioned it earlier, some people with alexithymia could have heightened awareness into these physical sensations, but have no acknowledgement that these physical sensations are connected with an emotion. And there's a misidentification of these physical sensations as pain.
So it's a way for the body to send you an alert that something's off. And I also think in our medical model, we don't look at pain so much as being an emotional suppression, but rather more biomechanical.
Yeah, I would say that's true. And I think a lot of people, but it's all in your head. But what is that? Yeah. What does that mean? It's not just all in your head. It's not all in your head. That's making too light of it. And it's just to make it almost takes the power away from the individual. Right? Because the person is in power of this, Yeah.
It's all in your head. That's where everything is.
Exactly.
Where do you expect it to be? All in your head? Confused now.
So accurate.
I don't know. I think I've run out of questions. I've run out of infographic stuff. So I'm at a loss.
Hopefully you guys got enough material for your show.
I think we have enough material for our show. Absolutely. You guys have been great. We've learned a lot. And usually what Deb and I do is we do 2 hours with you guys, and then we do another hour of us talking about what the heck did we just learn? Because that was mind blowing. And we'll probably do that and we'll get another episode out of it.
Oh, fabulous. We really appreciate you guys inviting us and just giving space to this topic. Because, as we said, the more we can raise awareness and the more people can think about this and how it's so connected to all the other aspects of their therapies and their day-to-day functioning. That's amazing.
Yeah, let's get the word out. And anything that you guys want us to throw up in the show notes, please do. And we tend to talk about things like if it's a website or something, we'll talk about it episode after episode. So anything that you have in terms of resources that can help folks that have problems with alexithymia, let us know.
Yeah, and I sent you guys an email with some links to that communication training. But 2 of the programs I linked in were both, they're both supported by ASBI, which is the Australasian Brain Injury Society on this side of the world. And they've got a store with fairly affordable resources for clinicians that they have converted most of them to PDFs to make them easily, convertible across international borders. But, there's some stuff on face things. There's the communication partner training. There's conversational training. So for clinicians who are just kind of looking for a space, and then Don, hopefully you'll be able to share that app soon. That would be exciting.
I just have one more question. Do you write these grants or do you have someone who helps you do that?
She does it. She wishes she had somebody to do it.
Exactly.
Just trying to find out what other teams are, what their operating process is here.
Are you the principal investigator on most of these? Yeah.
Yeah.
So
I am.
It's up to her.
Mm-hmm.
You might get somebody to write a subsection of something that they're an expert in, but usually it's the principal investigator that does that stuff. Yeah.
Yeah. Typically the lion's share, and then you have co-investigators. And so you'll have them kind of read through, make comments. And then if you have a co-investigator that has a different area of expertise of something that you're working on, they'll contribute and stuff. Way back when all of this alexithymia stuff I got started with this, my university had convinced me that I needed to do a startup company because, they were trying to say, well, you guys are all creating really cool things and we could be creating products, right? And I was intrigued by this because I'm tired of creating things that sit on the shelf, right? And that don't get utilized. And what I was told with this, well, if you have a business, if you're creating this product, the whole point is you're going to be getting this out there. It's going to be disseminated. People are going to be adopting it and utilizing it and all of this stuff. And I'm like, cool, but I'm not a business person. And I'm certainly, I'm not a capitalist. I'm not a business person. So that is very contra me, but if this can get out there and help people, that's great. Ultimately it turned out that really, really wasn't for me. And so I had created this business called Emote Ed. So emotional education combined, Emote Ed. And I had it for a couple of years and that sort of, I dissolved that because it really is not my jam. But when I was doing that, they did give us additional grant specialists that were supposed to help us with getting business grants.
You can't do everything.
No. And I'm much more excited about this app now that the folks from the UK have created and said, I'm like, oh my God, you put all this work into this. This looks amazing. How much is it going to cost? And they're like, it's free. I'm like, what?
Oh my gosh.
I'm like, oh my God, that's so novel. How awesome. And, it just makes my day, that's what this is about, is getting it out there, not creating barriers to access to this stuff. There's already too many barriers to begin with.
Yeah, I agree. Making it free or as close to free as possible whenever we can.
Mm-hmm. That's wonderful.
Okay. All right. We need to let these guys go.
We do.
Hey, take care of that eye, Barbara. Thank you guys
Thank
so
you.
much.
Yeah, I can't even tell. It looks fine, but yes, take care of it.
Perfect.
Yeah.
Beautiful eyes.
Well, thank you both. This has been fantastic. It's been a lot of fun.
Good. Let's keep in touch.
Thank you
Yes, that
so
would
much.
be great. We look forward to hearing the episodes.
Yeah.
Yeah, let us know. Keep us
We will.
posted.
It'll have
Yeah,
music behind it. It'll be very nice. Very nice.
Cool. Well, awesome. Well, thank you so much for your time. And Barb, we'll be in touch. I'll email you.
Yeah, that sounds fabulous, Dawn. We'll talk soon. Thank you.
Thank
Have a
you.
good night, guys, and a good day, Barb.
Thanks. Bye.
Thank you so much for listening to this episode. We appreciate your support and would love to hear from you. Ask us questions and share your thoughts by email at NogginsAndNeurons@gmail.com. That's Noggins, the word and, spelled out, neurons@gmail.com. If you like what you heard, please share this podcast with others you think will benefit. Also, be sure to subscribe and leave us a review. We'll catch you next time on Noggins and Neurons, Stroke and TBI Recovery Simplified.